Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Sanjay Sharma in London, UK, with whom we would like to discuss the benefits and risks of physical activity, exercise, and particularly high-performance sport immediately before the opening ceremony of the Paris 2024 Olympics. Dear Professor Sharma, dear Sanjay, it's a particularly pleasure for us to host you tonight.
Thank you.
Well, to all our viewers, let me just try to just briefly introduce you. Dr. Sharma is Professor of Sports Cardiology and Inherited Cardiac Diseases at St. George's University of London. And he is the Medical Director for the Virgin London Marathon and Consultant Cardiologist for the Cardiac Risk in the Young Sports Cardiology Clinic at St. George's Hospital. And as one of the leading sports cardiologists here in the UK, Professor Sharma acts as the cardiologist for the English Institute of Sport, British Rugby League, and the British Lawn Tennis Association. In the London 2012 Olympics, he led the medical team for the triathlon, marathon, long distance cycling, open water swim, and the 20K walk. I hope I got those all right. And he was also the lead cardiologist for the polyclinics during the Olympics and the Paralympics. So, Professor Sharma, we're really glad to have you here tonight.
It's a pleasure to be here.
We would like to dedicate tonight's webinar to the memory of Professor Hans Köhler, who passed over in early July, suffering actually a fatal event during exercise. Professor Köhler was a leading academic and clinical nephrologist, a highly committed academic teacher at Marcus at Home's home university in Hamburg, Germany, a mentor to many of us, and a wonderful person. May he rest in eternal peace. And now, Sharma, we are really looking forward to hear your presentation.
Right, thank you very much for having me on your program. I'm going to speak to you about the benefits and risk of high performance exercise. Now, the benefits of exercise on the cardiovascular system are well established. We know that people who exercise regularly are more likely to be of normal weight and less likely to have diabetes mellitus. They're also more likely to have a better blood pressure and lipid profile. And through curbing these risk factors for atherosclerosis, people who exercise regularly reduce their risk of a myocardial infarction by about 50% when they reach their 5th, 6th, and 7th decades. But if we actually look at the impact of these risk factors, it's relatively modest, as I will talk to you in a little while. But my objectives are to describe the benefits of exercise on the cardiovascular system. I will discuss the exercise paradox and the epidemiology of exercise-related sudden cardiac death. I will describe the causes of exercise-related sudden cardiac death. And I will discuss strategies to minimize the risk of sudden cardiac death. So I've already told you that exercise has benefits, but these are the benefits of exercise on atherosclerotic risk factors, and you will see that they are relatively modest. For example, exercise brings down the systolic blood pressure by approximately 5 millimeters of mercury, the diastolic blood pressure by approximately 3 millimeters of mercury, the total cholesterol concentration by about 5%, the LDL cholesterol by about 2%, and the body mass index by about 1.5%. These are still very important reductions, but exercise has many other benefits beyond risk factors for atherosclerosis. So apart from reducing the risk of atherosclerotic risk factors, people who exercise have a bigger heart that fills better and augments stroke volume better, thereby perfusing the organs better. It reduces aortic stiffness. It reduces systemic vascular resistance, improves left ventricular compliance, and increases plaque stability. Exercise also in the periphery increases capillary conductance, increases endothelial function, reduces oxidative stress, and reduces thrombogenicity. It also reduces heart rate, increases ion channel expression, and reduces increases electrical stability. And overall, exercise also reduces systemic inflammation. And in collection, all of these advantages result in an increase in the peak oxygen consumption, which is an excellent objective marker of fitness and probably the best measurable marker we have of longevity. If you look at this slide here, this is a relationship between fitness measured in METs versus the number of cardiovascular events per 10,000 man-years. And you will see that with increasing level of fitness, there is a linear reduction of about 13 to 20% in cardiovascular deaths per MET exercise. Now, to give you some idea, exercising at about 10 or 11 METs is like jogging or running at a 6 km/h pace. So pretty good, but you don't have to be absolutely brilliant. And you will also notice that as one gets fitter and as one exercises more and more, that benefit starts to be associated with slightly reduced rewards. So although there is a significant reduction at the beginning, if you keep exercising, it doesn't give you a completely linear reduction. So you don't have to do a lot of exercise to benefit. And this relationship between fitness and reduced cardiovascular mortality applies to the young, the old, men and women alike, those of different ethnicities, even those with comorbidities, including and also including fit and ostensibly healthy individuals. However, exercise does have its own issues in very rare instances. We know that exercise, apart from having all these amazing benefits, and everyone should be exercising, can trigger myocardial infarction and promote fatal arrhythmias in predisposed individuals. These are people that have already got an underlying substrate. There is also emerging evidence that exercise may worsen arrhythmic substrate. So for example, if someone's got something like arrhythmogenic cardiomyopathy or a laminopathy, exercise can make this worse. Deaths in sport are uncommon, but when they do occur, they appear to be counterintuitive because athletes are perceived as the healthiest segment of our society. And when a very high-level athlete is involved, it creates shockwaves in the community and raises many, many questions. As we remember with Ericsson collapsing during the European Championships in 2020, he was fortunate enough to survive, but this arrest occurred when we were at the peak of our COVID pandemic deaths. But during this event, 2 days worth of television focused primarily on him over COVID. In the Premier League, we had this occur only recently. So here we've got a football player that's gone down. This is Tom Lockyer, and you can see that he has gone down. He was also very fortunate enough to be resuscitated, and will address what went on in that huddle towards the end of my talk. But let's talk about the epidemiology of sudden cardiac death. First, it is uncommon, but when it does occur in young athletes, these are athletes aged under 35, the mean age of death is young, 18 years old. There's a large male to female, there's a large male predisposition over females with a 9-to-1 ratio in competitive sport and a 19-to-1 ratio in recreational sport. We know that the risk is greater in Black athletes. By Black athletes, I mean athletes of African or Afro-Caribbean origin. They're about 4 to 5 times more likely at risk of an exercise-related sudden cardiac death. We know that some sports afford greater risk. These are sports with a dynamic start-stop nature, such as soccer and basketball. Around 80% of deaths occur during exertion, and worryingly, over 80% have no warning symptoms. So if you look at the literature on sudden cardiac death in sport, the overall incidence is about 1 in 50,000, so not very common. However, there are multiple determinants of exercise-related sudden cardiac death, which include age, sex, ethnicity, and type of sport. And I'm going to show you some stats that caused a little bit of concern. So if we look at the demographic of the athlete, and we look at the incidence of sudden cardiac death per 100,000, we find that that risk is the lowest in females, less than one per 100,000. If we take men, that risk goes up to 2 per 100,000. These are white men. If we then look at adolescent white athletes and black adult athletes, that risk goes up to 8 per 100,000. And if we look at black soccer players or basketball players, that risk goes up to 20 per 100,000. So you see that the risk in a black soccer player or a basketball player is 20 times greater than the risk in a white woman or a white adult male. So we've got to, when we discuss sudden deaths, we've got to take into account the demographics. If we look at the causes of sudden death, they're due to a diverse spectrum of inherited, congenital, or acquired abnormalities. In young people, deaths are often due to inherited diseases such as the cardiomyopathies. Indeed, the cardiomyopathies are the leading cause of death, according to the literature. In the United States, the hypertrophic cardiomyopathy is the leading cause. In Italy, arrhythmogenic cardiomyopathy is the leading cause. We also see deaths from other congenital anomalies, such as congenital anomalous origins of the coronary arteries. In many instances, the heart is normal at postmortem, and deaths may also occur due to acquired diseases such as myocarditis or degenerative heart disease such as valvular heart disease. The prevalence of these conditions in young people is around 1 in 300. One in 300. The question really is, why do these deaths occur in certain demographics? And this is the theory. Sudden death in sport, more likely, it's governed by several factors. As I said, young age, male sex, black ethnicity, and certain dynamic sports. You need modifiers such as an arrhythmogenic substrate, abnormal genetics, the use of performance-enhancing agents, infection, unaccustomed activity, or exercising in an extreme environmental climate. For example, deciding to play football at 35 degrees when the weather has been very low, or going out in the freezing cold when you haven't been warmed up. And of course, there are triggers. Exercise itself is associated with surges in adrenaline, dehydration, electrolyte imbalances, acid-base disturbances, and even plaque rupture. And this relationship between modifiers and triggers, it is complex, can result in ventricular fibrillation in some individuals. And this may explain why a football player may play for 4 seasons and nothing happens. On the 5th season, they experience a sudden cardiac arrest. It's probably a combination of all of these things. Clearly, we know what causes death. We know the epidemiology of sudden cardiac death, and we know the demographics of people that die. We also know how to manage things like cardiomyopathy, and hence there are multiple incentives to identify these young individuals. But clearly, if we're going to assess these young individuals, what we need to know is the cardiovascular adaptation to exercise itself. And we know that people who exercise very vigorously, by that I mean exercise vigorously for 4 hours or more per week, undergo a constellation of structural and functional changes to promote a large and sustained stroke volume for prolonged periods. And these structural and functional changes also have a bearing on the electrical patterns seen on the ECG. We know athletes have increased chamber wall thickness and increased cavity size. Functionally, they have enhanced diastolic function. They augment stroke volume very well, and they have a high peak oxygen consumption. And on the ECG, we see increased vagal tone, and we see criteria for chamber enlargement or repolarization, and other criteria such as repolarization changes, which are also mediated by increased vagal tone. Here is the 12-lead ECG of a gold medal rower. Now, for those of you that are sports cardiologists or cardiologists with an interest in sport, you will appreciate that this is a relatively normal ECG for an athlete. But for those of you that are inexperienced, you will see lots of anomalies. Firstly, there is a sinus bradycardia. Then there is quite a marked right axis deviation, usually due to right ventricular volume overload. Then we've got the Sokolov-Leon voltage criterion for left ventricular hypertrophy. Then we've got incomplete right bundle branch block. And then we've got this J-point elevation with ascending concave ST segments known as early repolarization, which is best appreciated in the inferior and lateral leads. And a substantial number of athletes, particularly males, have ECGs like this. So if you're inexperienced and you're looking after athletes, then the false positive rate of diagnosing potential diseases goes up. And that's why these assessments need to take place with people who are used to assessing athletes. If we look at cardiac structure, we know that in general, athletes get a 10 to 20% increase in left ventricular wall thickness, a 10% increase in left or right ventricular cavity size, and a 45% increase in left ventricular mass. But the magnitude with which these physiological manifestations are seen is also governed by several factors such as age, sex, ethnicity, type of sport, and intensity of sport. And these need to be taken into account. Here is a bar chart describing, or shall I say, demonstrating the distribution of left ventricular cavity dimensions in Italian Olympic athletes. The blue bars are the males and the red bars are the females. The first thing to appreciate is that the males, the blue bars, have bigger dimensions, which is not surprising. They're generally larger. They've got bigger muscle bulk. They've got longer bones. They've got increased a longer tendon, so they can exercise more vigorously. The second thing I want you to appreciate is that nearly half of athletes have a left ventricular cavity size that exceeds the upper limit of normal, and an important minority have a left ventricular cavity size that exceeds 6 centimeters. And these biggest dimensions are normally seen in adult athletes, usually male with a large body surface area, engaging in endurance sport. When we look at wall thickness measurements, you don't see as many athletes demonstrating a wall thickness that exceeds the upper limit of normal. So if we call 11 millimeters the upper limit of normal for the general population, you will see that only around 2% of athletes get a wall thickness above 12, and they're invariably male. We hardly ever see a female athlete with a wall thickness of more than 12 millimeters. But you see this in about 1.5 to 2% of male athletes. Even if you look at LV geometry, we find that concentric left ventricular remodeling or concentric hypertrophy is much more common in males than in females. So females normally increase cardiac size through cavity, an increase in cavity dimension, rather than wall thickness. We've also got to take into account athletes of African or Afro-Caribbean origin. We have a very high proportion of these athletes in the UK, in France, and in Germany. So we've got to appreciate how they adapt to sport. Here is a distribution of wall thickness in 1,800 white athletes and 904 black athletes, all male. The black athletes are in the red bars, the white athletes are in the blue bars. And you'll see that whereas only 1.5 to 1.6% of white athletes have a wall thickness of 12 millimeters, a wall thickness of 12 millimeters or more is present, shall I say, a wall thickness of more than 12 millimeters is present in 13% of black athletes. So black athletes are more likely to show hypertrophy. These are the males. The other thing I want you to appreciate on this slide, that irrespective of ethnicity, it is very uncommon to see a wall thickness of more than 15 millimeters. And if you see that, then you are dealing with pathological left ventricular hypertrophy in an athlete. If we compare the same cohort and if we look at ECG abnormalities, the black athletes in the blue bars and the white athletes in the red bars, you will see that for most ECG anomalies, you see a higher prevalence of these ECG anomalies in black athletes compared to white athletes, particularly inverted T waves. Here is the ECG of Mo Farah in 2012, just before he won the 5,000 and 10,000 meter gold medal. He had had a transient vagal episode, and I was asked to have a look at this ECG and decide whether he was fit to compete in the Olympics. I think you'll all agree that if this chap was outside your hospital holding his chest, he would go straight to the cath lab to have an angiogram to look at his left anterior descending artery, because he's got J-point elevation and he's got deep T-wave inversion, suggesting that he may be in the process of having an anterior infarct. But this repolarization anomaly, comprising of J-point elevation with convex ST segments and deep T-wave inversion in leads V2, V3, and V4, is observed in around 13% of Black male athletes. We've investigated these people in a lot of detail. We've followed them up for years. We've genotyped these individuals, and we don't find anything wrong with them. In fact, if these individuals detrain, within 6 weeks, this pattern resolves. When they start training, it comes back again. So how do we prevent sudden cardiac death? Firstly, we try to educate athletes about certain things. We perform active screening, and we must remember the very important role of the external defibrillator. I'm going to start with screening, then talk about defibrillators, and then finish with athlete education. So, screening for serious cardiac diseases. I've already told you that death is due to a diverse spectrum of cardiovascular diseases, and no single test that we've got available will pick everything up. We are all very proud of MRI scans, but you'll all agree that an MRI scan will not diagnose long QT. It will not diagnose Wolff-Parkinson-White syndrome. Similarly, an ECG will not diagnose an anomalous coronary artery. But what we've got to remember is that deaths are uncommon, and we have thousands and thousands of athletes. So whatever we choose has to be cheap and readily available, because we add multiple tests to make a diagnosis, then cost becomes prohibitive. So what we're really left with is history, examination, and ECG. We know that the history has got a positive predictive accuracy of only 20% because most athletes have no symptoms at all. And whilst us cardiologists are very proud of our stethoscopes, most people that die suddenly during sport will not be detected with auscultation. In Europe, we rely on history taking, physical examination, and a 12-lead ECG. The 12-lead ECG does have the advantage in diagnosing ion channel diseases such as long QT syndrome and Brugada syndrome, and even picking up congenital electrical accessory pathways such as the Wolff-Parkinson-White ECG pattern. This is our data from our Pathology Institute on sudden cardiac death in sports people, where the autopsy was conducted by an expert cardiac pathologist. You will see this is a large data set of over 350 consecutive athletes with a mean age of around 29 years old, mostly male, 69% competitive, 40% dying at rest. And I want you to appreciate the pie chart that has the biggest segment. This is the red bit. And here, the heart was structurally normal. So our experience, certainly at St. George's, is that the most common thing that is found at post-mortem in an athlete that dies is a structurally normal heart. If we then go and perform molecular autopsy on these athletes, or if we go and screen their first-degree relatives, here is a chart of screening first-degree relatives of individuals that have died whose heart is structurally normal, we find that 40% of first-degree relatives of the decedents of people with a structurally normal heart have an ion channel disorder. So our feeling is that ion channel diseases are much more important than once considered, and therefore the ECG is probably more useful than we thought. Although the ECG is not the diagnostic test of choice for diagnosing cardiomyopathies, we've got to appreciate that a significant proportion of people with cardiomyopathy have an abnormal ECG. For example, the ECG is abnormal in 95% of people with hypertrophic cardiomyopathy, 80% of people with arrhythmogenic cardiomyopathy, and 75% of people with dilated cardiomyopathy. There were once concerns that the ECG would be associated with high false positives, but we have worked very hard to refine these ECG criteria, and we have come up with these international recommendations for ECG interpretation, where the green box represents normal changes, that take into account ethnicity, the black ECG pattern that I showed you, and the juvenile ECG pattern. And then we've got the red box, which we consider as definitely abnormal. But we've also introduced this non-specific box of left or right atrial enlargement, left or right axis deviation, or complete right bundle branch block. And if an athlete has just one of these in isolation, they go into the normal category. If they've got more than one of these non-specific findings, they go into the abnormal category. But the important things that one must worry about are T-wave inversion beyond V2 in adult white athletes, ST segment depression, pathological Q waves, complete left bundle branch block, or a wide interventricular conduction defect, ventricular pre-excitation, a long QT interval, and the Brugada ECG pattern. For those viewers that are watching, this is one ECG pattern that is always abnormal. And what you see here is T-wave inversion in the widespread T-wave inversion here. So widespread T-wave inversion is abnormal. I also want you to take notice of T-wave inversion in these lateral leads, V5 and V6. We see this in 0.5% of our white athletes, and we see this in 4% of our black athletes. I can tell you now that if you put someone, a white athlete, into an MRI scan with this ECG, you will find either a subtle cardiomyopathy or myocardial scar in around 60%. If you put a black athlete with this ECG into an MRI scan, you will find myocardial scar or cardiomyopathy in around 20%. So less likely to have a diagnostic yield in a black athlete, but even then, you do get some diagnostic yield. So we test all athletes who have lateral T-wave inversion in a lot of detail. Anterior T-wave inversion, by that I mean T-wave inversion in V2, sometimes V3, is slightly different because we see that in young adolescents, we see in females, we see it in black athletes, and we sometimes see it in endurance athletes. So the question really is, how do we differentiate anterior T-wave inversion like this, which you see in ARVC, from physiological remodeling? So what you've got to remember about ARVC, ARVC is not just about T-wave inversion in V1, V2, and V3. So when you're looking at an ECG with T-wave inversion in V1, V2, V3, you need to look for other features of ARVC, such as a prolonged S-wave in V2, T-wave inversion in other leads, low QRS voltages, ectopic beats, epsilon wave, or failure for the J point to be elevated. Here is a typical ECG of an athlete with ARVC, and you will see many, many anomalies here. You see T-wave inversion in V2, V3, V4, that's obvious. But if you look carefully, there are many other anomalies. There is delayed upstroke to the S-wave in V2. This is terminal activation delay. There is an epsilon wave, a positive deflection after the QRS complex. The QRS voltages are relatively small compared to the precordial leads. And that this person clearly had ARVC. So these international recommendations have helped us a lot in sports cardiology. They've reduced the number of positive ECGs down to 2.5% in white athletes, although we still need to do better in black athletes. They have maintained sensitivity for diagnosing serious disease at 92%. They've improved specificity for diagnosing serious disease from 87% to 97%. And the positive predictive value of the ECG is 17%. So there's almost a 1 in 5 chance that we will diagnose a cardiac condition if your ECG is abnormal, according to the international recommendations. I would like to just take a few minutes to talk about differentiating physiology from pathology, which is something that cardiologists worry about the most. For example, right now, I am testing many athletes who are coming back to compete in our Premier League. And there is always a lot of pressure to get things right and to get things done very, very quickly because clubs get very worried, especially when there is a signing. So how do we differentiate physiology from pathology when we're worried about something like cardiomyopathy? So here on the left, we've got left ventricular hypertrophy. And on the right, we've got a dilated left and or right ventricle with borderline low left ventricular ejection fraction. These thickened ventricles are often seen in black male athletes engaged in explosive sport, raising the possibility of hypertrophic cardiomyopathy. And these very big ventricles with slightly low baseline systolic function are seen in endurance sports people such as long distance runners and long distance cyclists. So athlete's heart versus hypertrophic cardiomyopathy. The common thing is wall thickness of 13 to 15 millimeters. This is how we tell the difference. If someone's got a family history of hypertrophic cardiomyopathy, if someone is a female or adolescent, if they've got these ECG changes that I've talked about, if they've got abnormal diastolic function, abnormal strain pattern, low peak oxygen consumption, myocardial scar in the hypertrophied segment, that tells you that they have a pathological hypertrophic process. Conversely, if their athlete is male, adult, the ECG only shows the normal ECG changes I've discussed. There is symmetric hypertrophy, large LV cavity, normal diastolic function, and high peak VO2, then that is athletic adaptation. I'll do one more. This is the one that causes us the most issues nowadays, the differentiation between dilated cardiomyopathy and athlete's heart. This gray zone is someone who's got a big left ventricle, whose baseline left ventricular ejection fraction is between 45 and 55%. So dilated cardiomyopathy, clearly if they've got symptoms or a family history of dilated cardiomyopathy, if they've got an abnormal ECG, if they've got a low peak VO2, or if they've got scar on the MRI. Physiology, if they're asymptomatic, and this is important, if the exercise echo, what we do is we do an exercise echocardiogram, and what we like to see is an increase in the baseline left ventricular ejection fraction of 11% or more. So if someone's got an LVEF of 50% at rest, if it goes up to 61 or 62, that makes us feel a lot better. In fact, we feel this is the most sensitive and specific method of differentiating between physiology and pathology. We've also noticed that if the peak ejection fraction exceeds more than 63%, this is also a sensitive and specific marker to rule out dilated cardiomyopathy. It's important to remember, after everything I've said, is that deaths do occur despite screening with an ECG. We know that the ECG will not pick up anomalous coronary arteries. It will not identify adrenergically driven ion channel disorders such as CPVT, and it will not pick up incomplete expressions of cardiomyopathy. You may be tested at the age of 17 or 18 years old and have nothing, and have developed cardiomyopathy at the age of 26 or 27. So if an ECG is done at a young age, it may not pick these up. We also know that the ECG will not pick up acquired conditions such as atherosclerotic coronary artery disease, commotio cordis, myocarditis, or electrolyte disorders. And this thing, atherosclerotic coronary artery disease, is a very big deal because if we look at most deaths in our community during exercise, they are due to atherosclerotic coronary artery disease where the ECG is not helpful. So how do we identify middle-aged and older athletes with coronary artery disease? Just reminding you again, these are deaths in the community, where the blue bars are the recreational athletes, and the red bars are the competitive high-profile athletes that I've been talking to you about. 94% of all deaths occur in recreational athletes. And if you look at their ages, you will see that most deaths occur between the age of 40 and 60 years old, predominantly in men. So mainly in men, 20-to-1 ratio between 45 and 55 years old. And if you look at the causes of death, in almost 90%, the deaths are due to atherosclerotic coronary artery disease. So if we take someone with a plaque and we superimpose upon that the stresses of exercise, such as metabolic factors, shearing forces, activation of the hemostatic factor, high catecholamines, you can see how this plaque may rupture and cause myocardial infarction. There is also the possibility that someone may have a tight stenosis, and this supply and demand imbalance could cause severe ischemia and put someone into ventricular fibrillation. Now, how do we identify all these people? Clearly, the best way to do this would be to do something like a CT coronary angiogram. But you've got millions of people exercising like this, and you can't be subjecting all of these people to a CT coronary angiogram. So you've got to be very pragmatic. And this is how the ESC attempt to identify people at high risk of coronary artery disease. This is dependent on symptoms, habitual activity, the 10-year risk score, which includes systolic blood pressure, the total cholesterol, and smoking status. If you've got a 10-year risk score of less than 3%, then you're considered low risk. If it's more than 5%, you're considered high risk or very high risk. And also, we look at individually of high level of established risk factors, and here are some of them. With a history of diabetes, a very high systolic blood pressure of more than 180, a very high total cholesterol of more than 8, a family history of premature cardiovascular disease in a first-degree relative, or a BMI of more than 20. I worry less about the BMI than I do about some of these other risk factors. So how do we progress with these people? Well, if you've got a low cardiovascular risk score, no risk factors, and you're physically active, and you want to run a marathon, I personally would find it very difficult to say you can't do it, especially if you're fit. If, on the other hand, you want to run a marathon and you've got a score of more than 5%, or you've got additional risk factors and you've not exercised very much, then we want to do some tests. And we would recommend a minimum of an ECG, echo, and an exercise stress test. You need that maybe on a treadmill, it may be functional imaging, or even a CT coronary angiogram. If these tests reveal high-risk features, then we proceed to coronary angiography with view to revascularization. If these tests are normal, then no further restrictions are necessary. Clearly, that may not be possible for everyone. Not everyone is in tune with their risk factors, and therefore it's important to have the availability of experienced staff or defibrillators present at athletic arena or in the community. Here is a meta-analysis looking at the impact of bystander presence, bystander CPR, and the use of an AED during a cardiac arrest. You're just witnessing a cardiac arrest increases that individual's survival rate by about threefold. If the bystanders start CPR, the risk of them surviving goes up almost fivefold. If an AED arrives within 3 or 4 minutes, the survival rate goes up by over fivefold. Here is data from American schools in between 2006 and 2007. These are 1,700 odd schools that had an AED. And in these schools, prompt CPR and the delivery of an AED shock was associated with a 64% survival amongst students and amongst teachers. So the survival rate was much higher than it would be in the community. In the UK, for example, if someone had a cardiac arrest in our community in the UK, then the chance of them surviving with normal neurology and coming out of hospital is only about 11%. So this figure of 64% is very good. But what do you need for that? You need good personnel. You need an effective communication system where people know how to communicate and get a defibrillator over to someone easily. People need to know where the AED is kept and it should be serviced. People should know how to use it, and people should be practicing CPR and use of AEDs. And the best results occur if CPR is started within a minute and a half and the first shock is delivered within 4 minutes. I showed you a survival rate of 64%, but if you look at some of these Japanese road races, you will see that the survival can be as high as 93%. So early AED is good. Now let me take you back to that Lockyer event, and you saw him drop. He had a reveal device in situ. So here he is, he goes down, and this is what the reveal device showed. So he has 3 VEs, and he goes into polymorphic VT at 16:15. And that degenerates into VF. And you will see that within less than 3 minutes, he is shocked out of it, and he came right around. And I think what this shows you is that early CPR, early response times may be the way forward if we're not going to be able to screen everyone. The education of an athlete is also important. We tell all athletes to exercise, or anyone exercising, to exercise within their limits that do not produce cardiac symptoms. We tell all athletes to avoid exercising during febrile episodes, lower respiratory tract infection, or during gastroenteritis. We tell all athletes to abstain from performance-enhancing agents. Anything that makes you go faster has to be bad for you. We tell those with long QT syndrome to avoid medications that may prolong QT. We tell all middle-aged, or advise all middle-aged and older individuals to pay particular attention to risk factor control. And this is my penultimate slide, where this group investigated deaths in middle-aged individuals. They found that 16% of those guys that arrested had pre-existing coronary artery disease. 56% had at least one risk factor for cardiovascular disease, and 36% had typical symptoms of cardiovascular disease in the prior week. So in conclusion, exercise is a risk factor for myocardial infarction and sudden cardiac arrest. A large proportion of adolescent and adult athletes with serious cardiac diseases can be identified by relatively simple screening methods. The evaluation of an athlete requires knowledge of the cardiac adaptation to exercise to help facilitate the differentiation between athlete's heart and cardiomyopathy. Sudden death during sports is most common, though, in middle-aged and older male athletes, and is most frequently due to coronary artery disease. The identification of high-risk middle-aged or older athletes requires a pragmatic approach to check for symptoms and risk factors, but I cannot emphasize the importance of the availability of an automated external defibrillator in such situations. Thank you very much for your attention, and I will take questions.
Yeah, so thank you so much, Professor Sharma. This was really a quick and deep dive into a lot of different topics, and you provided a lot of different data and information that is very crucial when talking about this topic. I also think that the sudden cardiac death is definitely the most dramatic and frightening event that one could experience when talking about adverse effects of exercise. And that scene of the soccer player going down to the ground really gave me goosebumps in the moment. So that's probably one of the most terrible things that you could experience. However, and you also mentioned coronary artery disease, for example, there are other potential adverse effects of exercise and heavy exercise that the athletes might experience besides sudden cardiac death. And you just started your presentation with one slide highlighting the beneficial effects of exercise with an almost linear relationship between the fitness expressed by the METs and the lower mortality rates. And I'm really interested in this topic because we can see that the more fitter the people get, the lower the risk for mortality. But also in this slide, you could recognize that in the end, there was this improvement was not linear anymore. It was stagnating. And this happened already at an area which you mentioned is not like excessive sports. It's running at a decent velocity. So I think, as you already mentioned, you don't have to be the professional elite athlete to benefit a lot from sports. So I think we agree on that. But what is about all these people that do more? And I think nowadays it's like excessive performance sports are very fashion, and there's a hype about not only extreme sports, but like a long endurance sports, marathon running, but also ultra endurance events. And these people, even though they are not participating in clubs and have professional medical assistance, do a lot of exercise. Do you think, what does the curve after that point, after that linear area?
Yeah. Well, I think one way around to describe this is let me start by saying everyone should exercise. It's the best medicine that we have, and we should be doing it. It's free. You can do it anytime, and it doesn't usually have side effects if you do it at a modest level. So the WHO recommends 150 minutes of exercise at a modest pace, divided into 5 doses. We know that if you do twice that, you do even better. But if we look at the meta-analyses involving millions and millions of people, then if you ask me what the sweet spot is, if I really cared about you and I wanted to look after your, not just your heart, about your general well-being, your stamina, your risk of malignancy, stroke, diabetes, then I think the sweet spot is 4 times that. Mm-hmm. So if you wanted to get the most out of physical activity, you should be doing 600 minutes of physical activity a week. Now, I don't mean going to the gym for 600 minutes. I mean walking from A to B, going upstairs, being on your feet. 600 minutes of that is the best. So that's 4 times what the WHO recommend. If you look at other data sets, they show, as you said, that the risk, the benefit goes down. So your benefit's very good, and the more you exercise, you get diminishing returns as time go on. And I think that diminishing return point starts at about 8 or 9 times the current recommendations. And after that, there is, now, I don't know if it's a U-shaped curve or whether it's a bathtub curve, where there are no benefits, but the detrimental effects don't start until quite late. But you're absolutely right that too much of anything can be bad for you, whether it's water, vitamins, or anything else. And just like too much exercise causes harm to the knees or the spine, too much exercise must cause harm to the heart in some predisposed individuals, even if they don't have an underlying cardiomyopathy. And probably the best example of that is atrial fibrillation. We know that atrial fibrillation is 5-fold greater in middle-aged fit people, really fit people, men, compared to people who exercise at healthy levels. So that's probably one very good evidence that that people run into trouble. And we see it as a sport cardiologist, I think I deal more now with AF in people who've exercised all their lives, cyclists and runners, than I deal with anything else. So AF is one. If we look at coronary artery calcium scores, we now know that people who exercise don't have low coronary artery calcium scores. In fact, they have slightly higher coronary artery calcium scores than people who exercise moderately. So if you look at marathon runners versus people who jog 5 or 6 kilometers twice a week, these marathon runners have more coronary artery calcium. About 1 in 5 have a coronary artery calcium score of more than 100. If we look at myocardial scar, we see that in 11 to 18% of male athletes. And we also know that in some individuals, excessive exercise may cause right ventricular dysfunction. So there are these 4 factors: maladaptation. What we don't know is why some people get them and others don't. So genetics must play a role, as must diet and environmental stimuli as well.
So what I was wondering is, if we have these data that there are adverse effects on the heart when you perform excessive sports like the coronary artery disease and atrial fibrillation, why isn't there the data that also shows this on mortality and on the heart outcomes? Because I think the number of persons performing that excessive exercise would be there. Is it just because it's so hard to get out the confounding, because these people have more beneficial effects on their life besides the sport, because they also live healthier? Or how do you explain that you don't know if it's a U-shaped curve or a bathtub curve?
Yes, and I think you've asked a very pertinent question, and your statement is excellent. Although I've told you that they get AF and they get increased coronary artery calcification and they get scarring, we have not been able to link these pathological entities to high mortal events. And as you rightly point out, there are several factors responsible for this. It may be that they negate their risk of an adverse event because of all the other beneficial effects that exercise has, such as they've got more stable electricity. They may have less systemic inflammation in their bodies. the rest of their body and their vasculature is able to cope with all of this. For example, the arteries distend much more easily compared to a sedentary individual. So there must be those benefits as well. And it's also likely that these guys are less likely to be smokers. But you could also argue that the people that can do this, run marathons again and again and again, are also superhumans, that they've got a better genetic constitution than the general population. If we look at the Tour de France athletes, they do crazy things. Now, I don't know whether I should even say this on YouTube, but there are lots of stories about doping in this athletic cohort for them to do this. But if you look at their risk of malignancy, it's 90% lower than in the general population. And I think that just tells you that it's a special human breed that can do what they do. They really are the tip of the iceberg and not the general population. So it's very difficult to use them as our guide, because they're probably a little bit superior to many people in the population.
So maybe if you would try to conclude, if they would ask you, should I stop doing such excessive exercise? Just from an epidemiological point of view, you could say that we don't have the evidence that so much is still beneficial. Less would be okay too. But besides some potential side effects, such as the cardiomyopathy risks or coronary artery disease risks, we also don't have the evidence to say that it's really health risky what you're doing, because the higher risk for mortality is not proven. Or how would you conclude?
Yes, I would say, if I was giving advice to a friend, I'd say, if you want to really benefit yourself, you should be doing 4 times what we say, 100 minutes. If you want to run marathons, you're doing it for your own aspiration and ambition. Whether this gives you a longevity advantage is questionable. There is emerging evidence that people who exercise for life at this level do, a substantial portion, do develop problems, but we have not been able to link these problems to deaths. So I wouldn't scare them too much, but I would say that as a scientist and a clinician, I'm keeping my ear to the ground.
Okay, thank you so much. I think as we already are advanced with the time, I would pass the microphone to the other moderators for further questions.
Thank you from my side as well. I wanted to have a quick question, Professor Sharma. I mean, I'm overwhelmed by your talk, and I think many of the questions that we have internally discussed earlier, you already alluded to, and I'm fascinated particularly by the way you made this so pragmatic. And this is where I wanted to ask one question, because as you mentioned, there's no way to get everybody into an MRI, and even an echocardiography is difficult. You told us a lot about ECG changes. What's your thoughts on artificial intelligence there? I mean, these things are very subtle. Most of them would, as you said, would think they are pathological if we're not so familiar with athlete ECGs. And AI, artificial intelligence, obviously has a problem there, because if we feed that machine with the normal ECG of normal population, they will also pick these ECGs as pathological. So, but that, on the other hand, would make it easier if we put the right information into the machine. Is that going to come on the broad range at low cost?
Yeah, I think you're absolutely right. Artificial intelligence is the way forward, and certainly ECG is probably the first place where we should start, because millions of athletes have had ECGs, millions and millions. We only put an athlete in an MRI scanner. We don't put normal people in an MRI scanner. So an athlete only goes in an MRI scanner if they've got symptoms, family history, ugly looking ECG, or if the echo raises questions. So we cannot use MRI data at the moment to say, look, this is normal in an athlete and this is abnormal, unless, of course, we did thousands and thousands of athletes. But what we can do, and we have to, the international recommendations, for example, are already programmed into ECG machines and are used in the United States by sports coaches who are not cardiologically qualified. But the printout comes back as a green, it said you're fine, or a red that you're not fine, and every now and then an amber. So those coaches can suddenly say, look, we've only got 2 reds. These are the 2 guys we're going to send to the cardiologist. Everyone else is cleared. So that is happening. I think what is required, and it's expensive and it's hard to justify, is that we put all these young football players into a magnet, or these basketball players, and say, right, we're going to do an MRI scan. Some people have tried doing that, but they've been worried about giving gadolinium because of this tiny risk of nephrotoxicity and the ethics of that. We've managed to do it with veteran athletes because we wanted to see the effects of exercise on the heart. But even then, we only have a cohort of 500. And you cannot use just 500 to say this is the full story. You need much more than that. But I think what is required is machine learning will be better. But see, the other thing you need is an adverse event, because you need to link a scar pattern to an adverse event before you can train the machine, say that was bad, that wasn't so bad. So I still think we're a long way away with MRIs in sports people. But as you already know, CT coronary angiography and fat attenuation indices are here, and they are putting radiologists out because they are better than radiologists at identifying risk. And I think a day will come where the machines tell us more than we tell ourselves, but you can never get rid of the doctor because it's the doctor that has to make the final decision.
I would have two questions with regard to, firstly, to biomarkers. You did a lot of research in that field. Surely we are all aware that there may be an increase in troponin and in proBNP in people exercising, say, a marathon or something like that. Surely this is not measured regularly, but from time to time we see these people at hospital after a marathon or triathlon. So is there an upper limit that you would accept? Or is this just an individual decision then? And the second question would be, we discussed some weeks ago with Professor Halle from Munich, exercise in dialysis patient and some other issues. And he told us that intra-exercise hypertension has gained some importance in recent years for explaining part of the changes that occur and might also contribute to atrial fibrillation. So how relevant is for your practice to measure blood pressure during exercise?
Again, so let's deal with your first question, biomarkers. So if someone ran a marathon, then the chance of them having a raised troponin and a BNP is about 80 to 90%. So we know that people who exercise very vigorously do have troponin leaks and they have high BNPs. And these can sometimes result in false diagnoses. For example, if someone goes into hospital with a collapse after a marathon, so even if it's obvious it wasn't cardiac, and they have a trop measurement, and that trop measurement is elevated, say it's 6 or 7 times higher than it should be, they might be admitted for further investigations. Generally, I can't give you the upper limit of what we call abnormal versus abnormal, but what we normally do is we repeat a 12-hour trop. If the trop is on its way down within the first 12 hours, it's very likely that that troponin is coming from the cytosol rather than the sarcomere, and probably was due to increased cell permeability. There is certainly data that people who've got very high troponins, and the Dutch group have shown that, are more likely to have coronary artery disease than people who've got lower troponins. But again, more data is required. In terms of your second question, we have definitely shown a link. We haven't published it yet. We have shown a link between exercise-induced hypertension and high-risk plaque in male veteran athletes. Yeah, we've shown that. We've not been able to show a link between coronary artery calcification, but we have been able to show a link between high-risk plaque.
And should one measure from time to time blood pressure during exercise in people who, say, a patient coming to us as cardiologist, nephrologist, who exercises thrice a week, should he measure his blood pressure during exercise?
But I think if we're assessing an athlete who exercising, when we're putting them on the treadmill, then obviously we would be measuring the blood pressure anyway. And I think if you've got athletes who are mounting systolic blood pressures in excess of 220 millimeters of mercury, whereas before I'd have put this just down to big power output, big blood pressure, not a worry. I think now I will be slightly more inclined to give them advice about salt, maybe even consider antihypertensive medication, because as I said, there is now emerging evidence that an exercise-induced high blood pressure may cause issues. Now, obviously, if someone is only playing soccer and they do this 3 or 4 hours, that may be different to someone who's a triathlete who is training 34 hours a week. So I think if you've got a very high volume of exercise and you've got an exercise-induced high blood pressure, we would be keen to try and treat that, probably with something like an angiotensin II receptor blocker, which is better accepted and less likely to impede performance.
We talked a lot about LV function, and you showed very nicely those alterations one can see. And we already know that high endurance athletes develop alterations in right ventricular function today. And could you just give us a quick overview about are there patterns one should screen, or what are the most important features or alterations one can see doing echo in athletes focusing on right ventricle?
Yeah, I mean, people who exercise normally get symmetric enlargement of all chambers. So they just like they get an enlarged left ventricle, they should get an enlarged right ventricle and enlarged atria as well. Obviously, we know that in endurance cyclists and runners, the right ventricle is marginally bigger than the left ventricle. But I think if your right ventricular ratio to your right ventricular internal diameter to the LV internal diameter ratio is more than 1.1 or about 1.2, then we would think that that right ventricle may be excessively enlarged. But even then, you would need to see other things such as a reduced right ventricular fractional area change, regional wall motion abnormalities, or an abnormal ECG, or even exercise-induced arrhythmias coming from the right ventricle before you can label these individuals. We have definitely noticed that long-distance cyclists have a slightly bigger right ventricle than the left. And as we've discussed before, and the Belgian group have discussed, there is this term, exercise-induced ARVC, that may exist in some people. I don't think that's purely due to exercise. I think that's probably an interplay between genetics and workload on the right ventricle.
Well, Professor Sharma, we've already been taking your time for over an hour. We're so glad again for this wonderful talk and all these answers to our questions. So thank you very much indeed. Thank you for your excellent work. We enjoy reading from you, and look forward to everything that will be coming. To our audience, we're looking forward to the Olympics. There'll be 2 more talks from colleagues from Paris on nephrology topics as well during the Olympic Games. And we're looking to a lot more sports this summer. So thank you very much again.
Thank you.